But trust me, it's well worth coming and sitting down in this room to listen to Dr. Krigsman. I have to say that he has helped my 3 children tremendously, and I am so grateful. And be prepared. Learn. This man right here, as my mother says best, thank God and Dr. Krigsman. Here we go.
Thank you very much, Laura. That was very sweet of you. I want to begin by notifying everyone that Dr. Brian Jepson's book on the biomedical interventions in autism is available, and it is well worth your reading. You will learn a lot, and your children will be helped. And it's for sale at the Thoughtful House booth. Right around the corner. A shameless plug. Absolutely, Lisa. Okay, my topic today is the multiplicity of gastrointestinal pathology found in ASD. And before I begin, I would like to thank Autism One and the people that are running it, the administration, the people that do day-to-day work. I'm not going to name them because I'm going to miss out on some names, and I don't want to do that. But we appreciate all that you do for the disease and for treating the disease and for the families that are affected by it. Now, also before I begin, I just wanted everyone to know that the lecture I like to give the most, which I'm not going to be giving today, is the case for autistic enterocolitis. And what this lecture is an argument that I have been making for a number of years that demonstrates that autistic enterocolitis, or the bowel inflammation that is found in the majority of children with autism who have GI symptoms, which has been given the diagnostic label autistic enterocolitis, the argument that it is indeed a true disease. It's not a figment of anyone's imagination. This is not something that we want to plug. This is a disease that meets all the criteria, the scientific criteria necessary to label something as a disease. And those of you who would like to see the audio-video presentation of that can go to either of these 2 websites, and there are 2 different versions of the same lecture. A very quick run through normal anatomy, since we'll be speaking about the different diagnoses, the different GI diagnoses found in children with ASD. I use this screen on your left. This is the mouth. You swallow food, it goes down the esophagus. The esophagus has long been thought to be simply a conduit to get food into the GI tract. We now know a lot more about it, and you'll be hearing a lot about those diseases very soon. This is the stomach, because from the esophagus, the food goes into the stomach. From the stomach, it goes through about 8 to 15 or 8 to 12 feet of coiled, tightly coiled small bowel. And then it exits the small bowel in this area right over here, which is a terminal ileum, the very end, the very last few inches of the small bowel. And then it becomes the colon. The colon is a much larger diameter organ than the small bowel. And products of digestion, mostly stool at this point, goes up the colon, across, down, and out the anus over here. That's the GI tract. So essentially it's 4 major portions. There's the esophagus, there's the stomach, there's the small bowel, and there's the colon. And then, of course, the 5th, which is the mouth. And all of these major organs of digestion, from the mouth to the anus, have all been involved in autistic enterocolitis, but not just autistic enterocolitis, because it exceeds that definition. All 5 of these organs have been involved in numerous gastrointestinal pathologic diagnoses, and we're going to go over what the range of those diagnoses are. It's in no way limited to just enterocolitis. There are numerous other diagnoses that these children can have, and that's the main focus of what I want to speak about today. Starting up in the mouth. This is the back of your throat. Through this hole is the very beginning of the esophagus, and it's, if you're looking at a person, it's about their neck, the neckline. This is what you're seeing in this picture. This is an endoscopic view taken at an endoscopy. What you see are lymphoid nodules, and large lymphoid nodules So even on the palate, this is the posterior or the very back of the palate, the bottom of your throat. It's the area where if you gag on something and choke on something, this is the spot where you feel that the gagging and choking is occurring. The very beginning of the GI tract, and that's where we begin to see these enlarged lymphoid nodules. So there's even that high up, there's already an immune response to things that are coming down the GI tract. Another photograph of it as well, and you can see there are some areas that appear normal. This area is normal. This area will be normal, but these areas are all lymphoid nodules. Lymphoid nodules in and of themselves are not a disease, and you're going to be hearing, you probably have heard from Dr. Wakefield quite a bit about lymphoid nodularity. It's not a disease in and of itself. It's an immune response. It's a normal function for the immune system to respond to things that it sees as foreign. But when that response is excessive, and when that response is exaggerated, and when that response is accompanied by inflammation, then that sheds light on the fact that the lymphoid hyperplasia is in fact pathologic. It's not something that the GI tract should normally be doing, but it's doing in an excessive and abnormal way. So what do we see in the esophagus? Just a list of the various diseases that we see when we look in the esophagus and get biopsies. And we're going to show photographs of most, if not all of these. We find what I've called an Eosinophil-Laden Esophagitis. It's not reflux esophagitis. It's not classic eosinophilic esophagitis. It's an esophageal inflammation that's laden with eosinophils, more than we normally see, but not quite as many to allow us to make a formal diagnosis of eosinophilic esophagitis. How many of you here, by the way, are physicians? Okay, so we have a few people who know about what eosinophilic esophagitis is. For those of you who are not physicians, not healthcare workers, the next item of eosinophilic esophagitis is a more recently recognized entity in which the esophagus is very heavily infiltrated with eosinophils. Eosinophils are a subcategory of white blood cells that are most notably found in classic allergy. So if you have a child with a classic food allergy, a classic milk allergy in an otherwise healthy 2-year-old, if you were to put an endoscope in their esophagus and biopsy it, you would expect to find a lot of eosinophils, a markedly elevated amount of eosinophils, very concentrated. These kids, children with ASD who have esophagitis, will very frequently have a lot of eosinophils in their esophagus also, but not quite to the extent, not quite at 25 to 30 cells per high-powered microscopic field that allows you to make a diagnosis of eosinophilic esophagitis. Gastroesophageal reflux disease, we see a lot of that in these children. Erosive esophagitis, a lot of junctional esophagitis. If you recall the photograph in the slide above, right where the esophagus joins with the stomach seems to be a very, very sensitive area for these children, and we see a lot of pathology in that one location. In normal reflux disease, where acid comes up in the esophagus, you'd expect to have the bottom of the esophagus affected as well, inflamed, irritated, eroded. The majority of these kids have a seemingly normal-looking bottom of the esophagus, but the junction seems to be very, very markedly affected, and we don't quite understand why that is yet, but we'll show some photographs of that in just a minute. There is H. pylori, Helicobacter pylori junctional esophagitis. H. pylori, as many of you probably know, is a bacterial infection that mostly infects the stomach, can cause a lot of abdominal pain, can cause ulcerations in adults and children. And what we found in a few children is that H. pylori is actually affecting the junction of the esophagus and stomach, a very unusual condition. Barrett's esophagus. Barrett's esophagus is a condition where where the lining of the esophagus undergoes a change. The cells that make up the lining of the esophagus undergo a metaplastic change where the appearance and shape of the cell changes. And when that happens, that's the very first step towards moving towards cancer, progression towards cancer. So Barrett's esophagus is a known early condition. That is, it precedes cancer. Not that Barrett's esophagus will become esophageal cancer. Only about 5% of Barrett's esophagus actually evolves into cancer. But that certainly is, it's known to be a precancerous condition, and Barrett's esophagus, when it's there, has to be taken very seriously. We monitor for it, and we do a number of different interventions to make sure that it does not progress into esophageal carcinoma. And very interestingly, a lot of the children with ASD and esophagitis, or ASD and abdominal symptoms, have been found to have Barrett's esophagus, and that was something that we did not expect to find. And finally, Candida Esophagitis, which is very rare. We've actually seen on less than a handful of children where there's actual Candida, there's actual fungus infestation of the esophagus. What does Barrett's esophagus look like? Again, on the photo on the screen on the left, you see here a small island of salmon-colored esophageal tissue, and that is the Barrett's mucosa. That is distinct from the mucosa, from the tissue around it, which is pink, and it's not quite as dark. And when you biopsy these little salmon-colored patches, you find that those cells are metaplastic. For those of you on this side, these are the salmon patches. Through this hole is the entrance to the stomach. So this is the junction of the esophagus. We're looking down the esophagus towards the entrance to the stomach. This is a photograph that really depicts what I've called the Eosinophil-Laden Esophagitis, so that the mucosa here is boggy. It's not the very bottom at the junction where the folds kind of pucker up. Through those folds is the entrance to the stomach. When you biopsy that tissue, what you find is an elevated concentration of eosinophils, but again, not quite the amount necessary in order to label it as eosinophilic esophagitis. Another appearance of the eosinophil-laden esophagitis are these streaking lymphoid nodules that we see, again, often in the bottom, in the distal third, the bottom third of the esophagus. And this is not normal. This is just another location now of the lymphoid hyperplasia, which you've been hearing about. So we saw a photograph of these enlarged lymphoid nodules in the back of the throat. This is an example of those enlarged lymphoid nodules in the bottom of the esophagus as well. Classic eosinophilic esophagitis would look like this. You see these concentric rings that go down the length of the esophagus, and this is not normal either. The normal esophagus should be smooth, should be a tubular appearance, and this is classic eosinophilic esophagitis, and on biopsy you see a very heavy concentration of eosinophils in the mucosa. A picture of GE junctional, the GE stands for gastroesophageal junctional ulcerations, that we see are over here in these photos, are small little ulcers in the area of the junction of the esophagus and the stomach, which normally, of course, should not be there, and these are very painful for those children who have them, and these are not accompanied by classic reflux or acid changes. There seems to be an unusual type of ulceration that occurs right at the GE junction of a number of these children. Another finding in the esophagus that we see is a nodular esophagitis. Now, this photograph came from my oldest patient, who was 37 years old at the time, and he had an entire lifetime of untreated bowel symptoms. So I see him after 3+ decades of his autism and his horrendous bowel symptoms and pain and diarrhea, and I put a scope in, and you know, this is what we found. And what we suspect, again, this is just one patient. I've never scoped anyone that old with autism. But I suspect that this is an advanced condition of what we're seeing in so many of our 3, 4, 5, and 6-year-olds. Bile reflux esophagitis. You don't just reflux acid, you can reflux bile as well. This is a photograph of this dark-colored fluid that lines the wall of the esophagus, and this actually may be some stool as well. So people who have a motility problem, they're unable to pass the products of digestion through the GI tract towards the anus. that series of consecutive contractions and coordinated contractions of the small bowel and colon that keeps things moving towards the anus, if that synchronized contraction is disrupted, then you're going to get movement of the intestinal contents back up into the stomach and the esophagus, and that will cause either stool reflux or bile reflux, and that's what we see very often in these children as well. Candida esophagitis, these little white spots that you see, on biopsy, we had the pathologist do special stains looking for fungus, and sure enough, those stains did in fact reveal that those were bona fide fungus. We don't see a whole lot of this. There's lots of suspicion, of course, that there is a fungal overgrowth or a fungal abnormality in these kids, so it's very exciting when we actually saw it in this patient. Now, that's the wide array of esophageal lesions that we've seen in these children. I didn't even show a picture of classic reflux esophagitis because that's just garden variety. That's like nothing special about that, but that also exists in these kids as well. So if you dealt with a child without autism and they had any one of those conditions where the esophagus is inflamed or is irritated, they would say, you know, Mom, Dad, it hurts when I swallow, or it's hard for me to swallow, which is different than pain. There's painful swallowing versus difficulty swallowing. Those are two distinct symptoms, but both of those symptoms would be something that a child who is communicative would convey to their parents. I feel like something is stuck in my throat. I have heartburn. They feel acid or things coming up in their chest. My stomach hurts after I eat. Or a parent will tell their kid, your breath stinks, which also is one of the common symptoms that children with esophageal disease have. But these are things that in the children who don't have ASD, they'll communicate with you and let you know something is wrong. What happens if you have ASD and you're either nonverbal or poorly verbal? Then how would you convey the sense that you can't swallow, or it hurts when you swallow, or it burns in your chest? Well, they get irritable. They have tantrums. They'll bang on their chest. They'll point to their throat. They avoid food. They just don't eat. They can go days and days and eat only one thing. And now that may be behavioral. I'm sure in many cases it is behavioral. But it also, in our experience, and many, many times, has been that their food avoidance is an intentional way for them to avoid eating, because eating makes them feel lousy. It hurts. Irritability after meals. They eat a meal and they have a tantrum. So, and also, of course, bad breath. So these are very generic symptoms. You don't get the specific location of a symptom that we rely on as physicians to help guide us in what diagnosis to make or what tests to even order. Moving on down to the stomach. Stomach is, again, over here, and it's primarily a bag that contains food before it goes into the small bowel. Lots of digestion occurs in the stomach. What types of lesions do we see in children with ASD in their stomachs? Far and away, the most common lesion we see is what's called a reactive gastropathy, which is actually a very unusual condition in adults. You can get that in response to external stimuli to the stomach, so that adults who are taking Motrin or ibuprofen, for example, if you biopsy their stomachs, you'll find a reactive gastropathy very frequently. If you're overdosing on supplements and vitamins, you can get a reactive gastropathy. These kids, even the kids who what we call treatment naive, who come to their first endoscopy never having been treated with any supplements or any vitamins or any Motrin, no medications, they have this very intense reactive gastropathy, and it seems to be one of the hallmarks of their gastrointestinal disease. Here they go back to pylori gastritis, very common thing, nothing to do with ASD in particular, and it's not seen more frequently in children with ASD than in non-ASD kids, but we see, of course, we see that as well in these kids. Acid peptic gastritis, acid-related disease of the stomach, again, not unique to children with ASD by any means, but seen very frequently in them. Gastric inflammatory polyps, this is something unusual that you don't typically see in normal, healthy children. But if you have some sort of ongoing inflammatory process that's chronic in the stomach, as we see the chronic inflammatory conditions that occur in the GI tract in children with ASD, we've seen a number of children who have these polyps in their stomach, and these are not precancerous adenomatous polyps like you have in adults, but they're rather inflammatory polyps, and the biopsies show an unmistakable pattern of ongoing inflammation. Gastric ulcers, okay? And this is just to remind me, this Austin child with outlet obstruction who had very remarkable ulcers of the stomach, and we'll show photographs of that. Eosinophilic gastritis and bile reflux gastritis as well. These are all this is the variety, the gamut of intestinal lesions that we've seen in children with ASD. What does reactive gastropathy look like? For those of you that are curious, well, this is a photograph of exactly that from a child from Missouri who is in severe pain. It's an 11-year-old child who is in severe pain, very, very self-abusive. And the parents had this distinct impression that he was having pain, that the self-abuse was in fact a response to him being in pain. Stomach ulcer. What you see there on the right side of the central hole, that kind of black circle, that is an ulcer. This is a classic gastric outlet ulcer, and presumably it's due to acid erosion in that location. The biopsies do not suggest anything other than acid as being the cause of it. This is a stomach inflammatory polyp that I was talking about before. That's a polyp tissue with a biopsy forceps next to it to give you an idea of the size. And on biopsy, this was not a precancerous or cancerous polyp. This was an inflammatory polyp that suggests ongoing chronic long-term inflammation. We see ulcerations of the stomach, but not the kind of ulcerations you see in classic acid ulcer disease. These are these pinpoint ulcerations that you see over here. That's one. There's like a mound of tissue around it. This is a close-up view of one of these lesions over here. And for those of you on this side of the room, the ulcerations are these small red dots with a small mound of tissue around it. And on the right frame is a close-up of that. Again, this is the result of ongoing stomach inflammation that does not seem to be caused by acid. It seems to be something different. H. pylori gastritis, which I do not have a photograph of, unfortunately, and non-H. pylori nodular gastritis. Very often when you see inflammation of the stomach that's markedly nodular, that's a tip-off that H. pylori is the culprit. We've seen a number of children on the spectrum who have this nodular appearing stomach wall without H. pylori. And again, it's just a sign of an ongoing immune activation. Remember, these are the same nodules that we've seen in the esophagus and in the bottom of the throat when there's chronic inflammation due to infection, due to allergy, due to autoimmune disease. It could be any of those. It's a nonspecific response to something, and now we see it in the stomach as well. And this is bile/stool reflux gastritis, where the motility was so impaired in this child that there's actually stool coming up in the stomach. So any of these stomach lesions, these gastric lesions, that would occur in a child who did not have autism, a neurotypical child, what would they say? How would they communicate their discomfort? Well, they would indicate that my stomach hurts, and they point. It's clear. The stomach pain, the classic gastric ulcer is an upper abdominal pain, so between the belly button and the bottom of the rib cage. And they would point to it. Pain after eating, postprandial or after eating pain is a classic symptom of stomach inflammation, and the reason that is because about half an hour after eating a meal, you have maximal acid output from the stomach. So if you have lesions of the stomach, they're going to feel the effects of that acid shortly after a meal. So pain after eating is a classic symptom of stomach inflammation. Nighttime awakening is, so the kid will wake up at night and say, I have a stomach ache. Nausea and vomiting, sweating and pallor. These are all things you typically would expect in a neurotypical child with the gastric lesions that we've just seen. But if the child is ASD and is poorly communicative, How would they manifest that? Well, again, irritability and tantrums, food avoidance, posturing, which we'll show some photographs of some of the postures that these kids assume in an effort to alleviate their pain. Head banging, vomiting. Vomiting is the same. It's an objective symptom. And nighttime awakening. Small bowel. Again, the small bowel is the area over here. So food goes from the stomach into the small bowel. What do we see in the small bowel? Well, in the duodenum, which is the first portion of the small bowel, we know a lot of patients have celiac disease. And one of the big problems that I have as a gastroenterologist treating children with ASD is that most kids, when they come to me, have been on a gluten-free diet for months to years. So when that happens, I really can never know if their GI symptoms are because of an underlying celiac disease. But there are a few patients who've come to me before going on a gluten-free diet. And of those, we have 2 that had classic bona fide celiac disease. So certainly, it can occur in these kids, same as any other kid. The question is, does it occur in ASD children more frequently than the rest of the population? That we don't know. We have very limited experience, again, with untreated celiac patients in the ASD population. Duodenal ulcers that are acid-related, which again are not specific for ASD. They're seen in many in neurotypical children as well, but we see them too in children with ASD. Duodenal ulcers that are not acid peptic, that are viral mediated or autoimmune, they look different, and we'll see photographs in just a minute. They don't have the appearance of the classic acid peptic duodenal ulcer. Nonspecific duodenitis, and the biopsies on a child who is gluten-free for a long time, so that we know that the biopsy we're looking at, the abnormalities are not due to celiac disease, but they have a lot of celiac-like features, and the pathologist will comment on this. What are those features? Patchy chronic inflammation, villous tip blunting, for those of you who this means something to, and intraepithelial lymphocytes, which is a very, very important finding. These are all things that when pathologists see it, they say, wow, you better check the patient doesn't have celiac disease. And I say, well, the patient's been off gluten for about 3 years already. Yet there seems to be some overlap, at least in the histologic, on a cellular level, the appearance under the microscope of children with ASD duodenitis often seems to mirror that which we see in celiac disease, yet we know it's not celiac disease because they have been gluten-free. And finally, allergic duodenitis, where we see marked lymphoid hyperplasia of the duodenum and also with an influx of eosinophils. And for photographs of what these look like, the nonspecific duodenitis is patchy redness. I chose this photograph to show you because what we have, these little white spots that we see. And at first I thought maybe this would be fungus, these mysterious fungus that we're all searching for. But that's not what it is. There's no evidence at all on the slides that these white spots that we're seeing in this biopsy are fungus, but rather they seem to be what's called dilated lacteals, and it's just a finding. It's a finding that we see not only in ASD children, but in other even neurotypical children and adults who have duodenal inflammation of any type. Dilated lacteals seem to be a concurrent finding with other classic signs of inflammation on biopsy. What's interesting about the ASD kids is that we seem to find these dilated lacteals and these duodenal white spots very, very frequently, and we don't understand why that is. But this is an example of the nonspecific duodenitis. Here is the marked lymphoid hyperplasia of the duodenum, and on the right side of the photograph you see there's actual ulceration with these with small little scab-looking caps to the lymphoid nodules. This is a classic duodenal ulcer, okay, that you would see in non-ASD children as well, with some degree of frequency, very marked swelling. There's some bleeding over there, as you can see. And this child, who is really nonverbal, had marked irritability, refused feeds, and would vomit a number of times per day. And when you have a child with ASD, you can imagine the multitude of things that you can attribute it to. Unless you took a look inside and saw this, you wouldn't know that this was occurring. Duodenal ulcerations, okay, these are not the types of ulcerations you would see with acid-related disease. These are these white pus-like spots that are covering the duodenum. And these are suggestive of an autoimmune or a viral mechanism, not of a straightforward acid-mediated disease. So, again, the same way to look at it, if a child does not have ASD, and they had any one of those duodenal lesions, how would they present? Well, they would say, my upper abdomen hurts me. They'd have pain after eating, nighttime awakening, and these would be elicited very easily by any gastroenterologist and any pediatrician. They would ask for specific symptoms, and the child and the mother would have very easy answers because you know from observing a child. Sweating and pallor, and in this case, you can even have diarrhea because once the small bowel is involved, you can have diarrhea as a symptom. But when you have ASD, as you all know firsthand, the picture is much more murkier. What's the irritability from? The head banging, the tantrums, the posturing, the vomiting. There are a myriad of different things, and you have no idea just from the presentation what the problem really is. Moving on down the GI tract to the jejunum and the ileum, further on down, and the small bowel. What kind of lesions do we see over there? Well, with the advent of PillCam technology, wireless capsule technology, we're able to actually, either in a patient who can swallow it, or we can drop it using the endoscope. It's a camera the size of a large vitamin tablet, and it takes 2 photographs per second, and it makes its way down the entire length of the GI tract, and it gives us an unprecedented view of the entire length of the gut, and in great mucosal detail. It's a magnification of 8 times actual size. So the clarity and the resolution you get with a wireless capsule exceeds that which we get from routine endoscopy. And we've never been able to visualize the GI tract before without having to cut a patient open. No X-rays can come close to this kind of visualization. Once we began using it on these kids, wouldn't you know it, we found all kinds of lesions there. And the most common lesion we see is our ulcerations and polyps and white specks. And what we're going to see here is what you're seeing in this slide is classic Aphthous ulcerations of these 2 areas. And the arrows point to it. These are classic. Here's a lesion with a erythematous or an inflamed area around the lesion. And for those of you on this side, these are classic Aphthous lesions. The term Aphthous lesion, by the way, it's an Aphthous ulcer. It's not an acid ulcer. There's no erosion. There's no deep erosion. It's a canker sore. An Aphthous lesion is really a canker sore, but that occurs not in the mouth, but rather deeper on down in the bowel. And these are all photographs taken with the PillCam. We also find small bowel erosive ulcerations. And in this particular patient, it occurred together with a protein loss from the bowels, that the inflammation was so intense in the small intestine that there was actual leakage of protein out of the body into the bowel lumen. This patient presented with a lot of swelling of his hands and his legs, and at capsule endoscopy, he was found to in fact have this large ulcerative lesion. Actually, he had hundreds of these that studded his small bowel. And in this particular case, he responded to simple dietary restriction. No other medications were needed. He was having a classic allergy. Classic allergy in the absolute classic sense of the word, IgE mediated, to a variety of foods. And he ended up needing to be tube-fed, and with the tube feeding of an elemental formula, the lesions disappeared, his swelling went away, his protein levels normalized, and the hope is to slowly desensitize him. But this is an example of, again, one of the things that we sometimes won't know is there unless we look for it. Okay, and here as well is a child actually he was 12 years old, who I first saw him when he was about 4 or 5, and he was having a lot of aggression. A lot of aggression was his big thing, his major symptom. And his mom, who was a nurse, was sure he was having pain, and she had been down that route, and nobody believed her. And many years passed, and I see him within the last 6 months. April, it was just April 12th of '07, and we did the capsule endoscopy on him. And he had, again, his small bowel was studded with lesions, and not quite the same as the last one that was classic allergy, but these are erosive aphthous lesions that you see here. And what's interesting, what you see here is the mucosa is actually up against the lens of the scope of the pill, of the capsule. So this is the appearance of the lesion pressed up against the lens. Whereas here you see an air bubble, so the capsule, the camera, is actually capturing a photograph of something through the bubble. So you get to see what it looks like from a distance. And from a distance, you see these small white dots surrounded by a dark red ring. And now those, I was very excited when I first saw that, because after years of doing colonoscopies and seeing that identical lesion of these white canker sore aphthous lesions with a surrounding red ring in the colon, now we know, using capsule technology, that the same identical lesion, and it appears identical photographically, is present throughout the length of the small bowel in so many of these kids as well. So if you do not have ASD and you had one of these lesions, which are similar to the lesions we see in Crohn's disease, you say, my stomach hurts, you have diarrhea, you can have constipation, you see mucus in the stool, there's vomiting, malabsorption, poor growth, low albumin. If you have ASD, right, then in addition to some of the objective symptoms like low albumin and mucus in the stool, you also have irritability, head banging, tantrums, food avoidance, vomiting, the same symptoms we've seen in the upper GI disease as well. Terminal ileum, the very end of the small bowel, as we saw before in the photograph of the anatomy. What types of lesions do we see in the terminal ileum, which is the last few inches of before the small bowel becomes a colon? Well, we see an ileitis, which is an influx of inflammatory cells in the ileum. And it appears to be, from the appearance, from a cellular appearance on biopsy, it appears to be either autoimmune or viral in nature. Does not appear to be infectious, as in bacterial infection. We found no bacteria on any of the biopsies that we've done. There's marked lymphoid hyperplasia, which probably Dr. Wakefield showed photographs of yesterday as well. And we've also found evidence of classic Crohn's disease in the terminal ileum of a number of these patients. And I'll show you photographs of what that looks like. These are 3 grades, three degrees of severity of lymphoid hyperplasia of the ileum. Now, on the upper left is arbitrarily, we call it mild. The right frame is moderate, and the bottom frame is severe. The bottom frame is the kind of LNH that you see in patients who have Crohn's disease. There's a very classic appearance when you do a barium study in a small bowel follow-through that these nodules make. It becomes like a cobblestone type of appearance. And this is what we very frequently see in these children. For those of you who have an appreciation for histopathology, the large lymphoid nodules is over here. This pale purple central core, or is what's called a germinal center. It's the area that's actively replicating. And you see this markedly active germinal center in active, severely active infectious or autoimmune diseases, or in lymphomas and cancers. And in fact, when I first began submitting these biopsies to the pathologist, he called me and he was all upset. He says, does this little 3-year-old have lymphoma? And I said, no, he just has autism. So it's okay, it's not a problem. This is ileitis, and again, for those of you who can appreciate the histopathology, this is an influx of inflammatory cells that are invading the integrity of the crypt. And I put this slide in because I mentioned before that we have found evidence of Crohn's disease in some of these children. We know that because of the presence of a granuloma. Granuloma, as many of you may know, is the absolute footprint, fingerprint, I should say, of Crohn's disease. It can be found in a few limited other conditions, but in a condition where you have bowel inflammation of so many other areas, and you find the granuloma, particularly in terminal ileum, it is Crohn's disease until proven otherwise. And again, we've seen it in a number of patients. So if you have these lesions of the TI, of terminal ileum, and you have, and you're neurotypical, and you can talk and communicate, what do you say? You say, my stomach hurts over here. It's in the right lower quadrant. Poor appetite. Johnny won't want to eat. They're nauseous. They can vomit. They can have a great urgency to pass stool. They can even have diarrhea. They can have constipation as well. But if you have ASD and you don't communicate well, irritability, tantrums, posturing, food avoidance, posturing, self-abusive behaviors, poor sleeping, head banging, vomiting, stool incontinence. And how many of those symptoms could be attributed to just the behavioral component of ASD? All of them. Finally, the colon, the very last area of the GI tract, the furthest from the mouth. What do we see when we look in the colon? Well, we find colitis, and that colitis, it could be viral appearing, it could be autoimmune appearing. We find colonic ulcerations, we find polyps of the colon. We have a number of children who have classic ulcerative colitis in whom we don't hesitate to give that label. The findings on biopsy are absolutely classic in those kids. Although I have to emphasize that in the vast majority of children who have colitis, it is nonspecific. It's a nonspecific colitis, so that it's not Crohn's disease, it's not ulcerative colitis, it's inflammation, it's not normal, but it does not fit the diagnostic category of Crohn's and ulcerative colitis. It's a very important point to make because when you go to your pediatricians and to your gastroenterologist, when you say, oh, my child has colitis, I heard all about it, and here are the sources. And if you use the term ulcerative colitis and Crohn's disease, when you communicate your knowledge with your gastroenterologist, you will lose them like that because they will know from looking at the photographs and at the basic pathology reports that it is not IBD, and it isn't. For the most part, it's a nonspecific enterocolitis. So terminology is really important when you want to convey the information to healthcare professionals who know quite a bit about colonic disease. We often see Crohn's disease in these patients. Again, not in the majority. It's a small minority that actually have classic Crohn's with the granulomas, but they do exist. And again, in the colon, we very frequently see marked lymphonodular hyperplasia. This is an example of the colitis that we look at endoscopically. The colon is patchy areas of redness. It's tubular. You don't have the house tray or the markings that you normally would see. This is a photograph of Aphthous ulcerations of the colon. If you think back to the pill cam photos we saw before, those white spots with the red halo around it, it's called the red halo sign, which we know of to exist in the colon in classic IBD. And these kids certainly have that. And it's what was so exciting, again, was that it's the identical lesion to that which we see in the small bowel. And what's even more interesting is that the concentration of these Aphthous lesions, these red halo lesions in the small bowel is much heavier than it is in the colon, which suggests that the primary location of the bowel disease in children with autistic enterocolitis is not the colon, which is what I thought a few years ago, but in fact is the small bowel. So we await more work on that. This is another photograph of these Aphthous ulcerations, the red halo signs of the colon. This is a nonspecific colitis. This is an inflammatory polyp of the colon. We saw one before of the stomach, right? And we certainly have seen it a number of times in the colon as well. And on biopsy, these polyps are not the adenomatous polyps or precancerous polyps that we get as adults. It is an inflammatory polyp, which is a result of long-standing inflammation. And I should mention also that there's one patient that we have who seems to have an inflammatory polyp in the small bowel that we captured using PillCamp technology. Well, what if you have these colonic lesions and you don't have ASD, so you can communicate well? You have diarrhea and cramps and constipation, but you say, it hurts. It hurts. You know, I can't hold it in to get to the bathroom. I have accidents. I'm incontinent. And you complain of these things. In ASD, you're incontinent and you have diarrhea and constipation, but it could be chalked up to being behavioral. Some photos. I'm going to show some photos of stools and other posturing and some of the classic symptom presentation, mainly because as parents, you are the front line. If you see your child with stools that look a certain way, or if you see your child posturing or putting pressure on his abdomen in a certain way, if you see certain patterns of behavior and you recognize that from the photos that I show, then there's a very good chance that your child has something wrong with their bowel that we can help them with. And by seeing these photographs, you now know that you need to make a very strong point and emphasize intensely with your pediatrician that you're demanding a workup and that you do not want your symptoms to be dismissed. So this is the typical diarrheal stool. The word diarrhea means different things to different people. Diarrhea meant to me 10 years ago this watery substance that comes out when you have a 2-day stomach virus. But what these children have, by and large, is not that type of diarrhea. Some of them do, most of them don't. Most of them have 1 to 2 bowel movements a day that look like this. They're yellow, they're beige. There's this black, grainy, sandy substance in it that we don't know what it is. There's food particles in there, and it stinks. It stinks like hell. And you know, I've heard all kinds of adjectives that are used to describe the smell of the stool. But you live it, so you know what I'm talking about. This is, if a child's potty trained and they have these types of stools in a toilet, it breaks apart on entry. This is one bowel movement of a 3-year-old child. This is a huge amount of stool. Snakes, the ribbon-like snake-looking stool is a sign, at the very least, of colonic dysmotility, and perhaps even inflammation on top of that, because the two of them can coexist. They often do coexist. So that's also a stool that should alert you that your child probably has a problem. This is the posturing I was talking about. These children will assume a variety of postures to put pressure on the lower abdomen. This child is laying on the floor, putting her hands in there. The well-meaning pediatricians thought this was masturbation, but it is not. It is pain. This child would sleep every night on their exercise ball with his doggy underneath his head as a pillow, and he stopped doing this. In all these cases, these children were all subsequently evaluated, biopsied, found to have one disease or another of their GI tract, treated for it, the symptoms of diarrhea and pain resolved, and these behaviors, this posturing, resolved as well at the same time. That's how we know that the two of them are related and that this is, in fact, pain. A lot of kids who are having pain will sleep like a Muslim in prayer, and this is the position that they assume. And again, we know that this is pain because when we treat them for symptoms like diarrhea, they get scoped, biopsied, we make a diagnosis, we give medication, this type of sleeping disappears along with their diarrhea and other manifestations of pain. Self-abusive behavior, just another autistic trait, right? No, it's not. Part of autism, no diagnostic criteria of autism includes self-abusive behavior. It's not part of the criteria to diagnose autism. And these children are, for the most part, very affectionate and very loving. And when they're aggressive to others, as well as themselves, it is, until every other possibility is excluded, the assumption has to be made that these children are in pain and they have to be evaluated for GI disease amongst other diseases as well. Now, a word about autistic enterocolitis, which we've touched on a few of these points already. It's not Crohn's disease. It's a new variant of bowel inflammation that does share many interesting clinical and histologic features of Crohn's disease. And again, it's important to point out that the bowel diseases present in children with ASD are not by any means limited to autistic enterocolitis, but they can be composed of the whole gamut of GI illnesses, in addition to something unique and special that we see in these children. The enterocolitis in these children can occur anywhere from mouth to anus. The most frequent sites of involvement are the ileum and the rectosigmoid, and this is our own experience and a review of almost 150 patients that we did retrospectively. And that's of interest, those sites of involvement, because those are also the most frequent sites of involvement of Crohn's disease. So it's another interesting overlap. It does not mean that this is Crohn's disease, but it makes you stand back and scratch your head and say, hey, this is really interesting. The gross appearance, notice the endoscopic appearance of lymphoid hyperplasia of the ileum and the aphthous lesions of the small and large bowel are outwardly and microscopically identical to those seen in Crohn's disease. Again, does not mean it's Crohn's disease, but it makes you scratch your head and say, this is really interesting. The affected areas are patchy and not contiguous, which is also a feature of Crohn's disease, but not ulcerative colitis. And various degrees and types of inflammation exist. There are very intense disease, mild disease, granulomas, etc. The reason why we can't label this, the autistic enterocolitis part of their bowel disease, we cannot label it as Crohn's disease, is because to date, there's never been a documented case of a full thickness lesion. There was a full thickness of the bowel wall in Crohn's disease is very frequently involved, and that's how Crohn's can spread actually outside. It kind of moves across the bowel wall and affects adjacent organs. It's never been seen, to my knowledge, in autistic bowel disease. And that is a classic, it's a cardinal feature of Crohn's disease. There have been no fissures, no perianal fissures that we've seen in this disease. We have not seen any fistulas, which is also a classic finding in Crohn's disease. And it appears that the cytokine population in this group of kids is different than in the Crohn's population. And this has been published by Dr. Wakefield and Paul Ashwood. So what do you do when you're faced with a child who's having tantrums, sleeping poorly, has chronic loose stools that are yellow, tan, grainy, and foul-smelling, that struggles to pass stools that are loose, who postures and is self-injurious, who avoids and refuses many foods, who has awful breath, who vomits and refluxes, is unpredictably aggressive, and the therapists say that, you know, of all the kids in my group, you know, we do this intensive behavioral therapy with him, and he just makes no progress, and he should be a lot further along than he is. So what do you do when you're faced with a kid like that? So one thing you could do is you can say, well, that's just what autism is, you know, that's how these kids are. But that's not what anyone should say, because all of this whole list of observations are in fact symptoms. These are symptoms of bowel disease. Not that it has to be bowel disease. It certainly can be behavioral, and in many cases it is. But we have seen time and time again where the symptoms in this list, either in combination or in isolation, are present, and a parent, because of their conviction, comes forward and says, I demand that a workup be done. And when we look at it, we find all kinds of interesting findings that you've seen in the above photographs. So the answer to that question, what do you do when you're confronted with those symptoms, is that you must consider the multiplicity of GI diagnoses, not just enterocolitis, but is there eosinophilic esophagitis? Is there a non-allergic esophagitis? Is there reflux? Is there Barrett's esophagus? Are there inflammatory polyps? Is there a duodenal ulcer? Is there a gastric antral ulcer? Is there duodenitis? Is there an erosive duodenitis? Is there colitis? Are there Aphthous ulcers scattered around the small bowel? These are all possibilities that exist in any of the kids who have food avoidance and tantrums, which is so many of our children. So back in October of last year, Autism Speaks decided to convene a panel of gastroenterologists and other non-GI doctors who were very experienced in treating children with autism to get together and have some sort of a consensus about the GI disease. So consensus is very difficult in general to get, but a very, very well done consensus was reached. And for the record, Dr. Wakefield and I both were present as part of that meeting, and Tim Bowie was there as well. And what came out of that was a very well done document that you can get from the website on the first bullet. It's a PDF, you can download it. I strongly encourage all of you to go to that site, download it, and if your children, or if you're a physician who's caring for these kids, if these kids that you're working with or you have exhibit any of those symptoms, you take this paper, you take this consensus statement with a number of very distinguished gastroenterologists, forgetting the autism people, but a number of well-published, regular gastroenterologists were there at that meeting and put their names to this. And this is a recognition that these possibilities exist in this group of children, and because they're non-communicative, they deserve to be investigated aggressively. So if you find yourself going to your pediatrician or to your gastroenterologist, take this paper with you, because there's a good chance they haven't seen it. The Journal of Pediatrics did not want to publish this for political reasons, I guess. But what they did was they provided Autism Speaks with a mailing list, and it was mailed out to all members of the American Academy of Pediatrics. But most physicians, myself included, get mail from these places 5 times a week and just toss it in the garbage. So chances are it was not read. But you bring it with you, and I think it will take you very far. What you as a parent should demand from the pediatric gastroenterologist or pediatrician is a careful history, a very thorough physical exam, baseline screening tests. Those all should be ordered, and actually that document, that consensus statement, describes what screening tests should be done. And they are essentially the ones that we do at Thoughtful House. So the agreement is that those are good screening tests. The next step, after the history and the physical exam were done, their conservative therapy can be employed even before doing anything invasive, no biopsies. We're not even at that stage yet. If you have a child who has diarrhea, who has constipation, there are some basic, foods you could take out of the diet. There are some motility drugs you could use short term. There are some laxatives you can use. Empirically. The word empirically means that without a definite diagnosis, based on an assumption that there is a problem there, and based upon what you know about the symptoms and the intensity, there's a good chance that this is a diagnosis. You could then try different medications. The medications that you can use empirically are those that will not alter the appearance of the gastrointestinal tract should one decide that a biopsy is needed at a later time. Now, we'll get back to that very important point in just a minute. If the screening tests are unrevealing and the symptoms persist, and you've done your interventions with laxatives and motility agents, some dietary therapy as well, but the symptoms persist, at that point, this child needs to be referred to a pediatric gastroenterologist for consideration of all of the above potential diagnoses, the whole gamut, the whole list of them. Those are all possibilities in this group of kids. If the gastroenterologist does not take your GI concerns seriously, if they do not feel that these represent true symptoms, if they think that all ASD kids are supposed to have diarrhea, and some of them do feel that way because of they eat dirt from the floor, etc. I've heard all kinds of stories. Or if the symptoms are dismissed as being behavioral, then you need to find another gastroenterologist. And there are many pediatric gastroenterologists who are very open, very, very open to the notion that these children have something unique and something different and something we haven't seen before. And the question is to find them. And they are there, and we get phone calls all the time. And they're all over the country. So it's not just in Austin. There are other physicians who are interested in helping these children. Most of the diagnoses described above require specific diagnostic testing, often involving direct visualization and biopsy of the intestinal organ in question. The treatment of the various diseases that we've seen in all the slides, once you get a biopsy, treatment of those diseases includes but is not limited to dietary avoidance and various medications. Types of medication used depends on what the diagnosis is. If it's an IgE allergic disease versus an eosinophilic disease versus non-IgE intolerance versus an autoimmune enterocolitis versus Crohn's disease versus an acid-mediated disease versus an acid exacerbation of a pre-existing disease, or food-mediated is a food exacerbated, these are all potential diagnoses that are added to the list of diagnoses you've seen from the endoscopy photos before. These are all possibilities. And the factors that need to be considered in choosing medications are besides what the diagnosis is the location of the disease. Is it the esophagus? Is it the stomach? Is it the small bowel? Is it the colon? Is it heavier on the bottom than on top? Is it heavier on top than on bottom? These are all things that would influence our decision about what medications and what dosages to use. So it is therefore a bad idea to treat empirically with medications that alter the biopsy appearance without first exerting due diligence to obtain a tissue diagnosis, because then what happens is as follows, or what very often happens is as follows. Consider strep throat as an analogy. You have a 4-year-old child, neurotypical, who has fever, 104 for 2 days, has a really bad sore throat, and take him to the doctor. The doctor looks at his mouth and sees these red, swollen tonsils with some pus and exudate on them, and says, we've got to do a throat culture to see if it's strep. And that's what the right thing to do is, and there's no question about that. That's standard of care. But a lot of kids don't like having a swab put in their throat, and they fight and they scream and they kick. And many parents will say, come on, just give me some amoxicillin and spare him the swab in the throat. I know it's strep. You know, 2 kids in this class have it, and what else could it be? It's absolutely inappropriate to give antibiotics, but there are very few exceptions. But those aside, to give medications, to give amoxicillin for that in that situation without first getting a tissue culture diagnosis. Well, why is that? Because let's say, again, strep throat, you treat for 2 days with your amoxicillin on the assumption that strep throat is there, and then 2 days later, Johnny still has fever and a sore throat. So then you're faced with the question, maybe the dose isn't high enough, or maybe it's resistant to penicillin. Maybe we need a different antibiotic, or maybe it's a virus and doesn't need antibiotics at all. And now the question is unanswerable, because you can't do a throat culture now, because now you have what's called partially treated disease. Even if there's worse strep that were resistant, perhaps, you wouldn't expect it to grow in culture when you come back 2 days later. And what that does is it commits the physician to a full course of treatment, which in the case of strep throat is a known entity. It's 10 days of an antibiotic. And now consider what happens if this were a child with autism and severe tantrums and diarrhea. Well, if you give prednisone to almost any disease known to man, you're going to make it a little bit better for the time being. If you give sulfasalazine or Colizal or Pentasa or any of the classic anti-inflammatory drugs, it may be helping the disease. If it's exactly the disease that you hope it is, you may be helping it. But what if in a month it's not better or only marginally better? And then the questions become the same as strep throat. And this very frequently happens. After a month or 2 of treatment, there's only minor improvement. Well, in that case, you want to ask yourself, maybe the dose needs to be increased, or maybe it needs a different medication. Maybe it's Pentasa resistant, but it's sulfasalazine sensitive, which is the case in many cases of Crohn's disease. Or maybe it's not bowel inflammation at all. Maybe it's just toddler's diarrhea. Maybe it's just diarrhea because it's a food reaction. And now these questions are almost unanswerable, because if you would then go to get your biopsy, the mucosa, because of the medication, has been changed. And it becomes difficult, if not impossible, to interpret the true disease once you've altered the appearance. So the things that can come out of that is, A, that you don't know whether there is bowel disease present or not. Number 2, you come to the gastroenterologist with partially treated disease, and it becomes impossible to figure out what's there. Third possible outcome is unnecessary treatment for a disease that is not there, because it may not be colitis at all. It may be reflux. It may be allergy. You could miss other diseases that are there but were not suspected. There's an inability now to monitor objectively for improvement of a disease. By getting a baseline tissue biopsy and knowing what's there, then when we subsequently go in a year or 2 or 3 later, we can know, have we helped this child or not? Was there a problem that we now know is gone? Another additional possibility, medications may worsen the symptoms, leaving more unanswerable questions. And also, and lastly, is the unknown effects of medications in a disease that is only now being recognized. It's important to recognize that although we throw around the term autistic enterocolitis as if we know what we're talking about, we don't know a whole lot about it. 5 years down the road, or 10 years down the road, we may really regret not having had that biopsy 10 years ago, so we can have a baseline where we were 10 years ago and learn from that, and know more about it 10 years later. So, not to belabor the point, one final analogy would be for these kids so frequently get biomedical interventions of a wide sort. To do chelation, for example, without first knowing if there is excess metals or what's being excreted, just to do generic chelation. I don't know anyone that's doing that, but that would be the analogy, because you don't treat unless you know what's there. Giving a full array of available minerals and vitamins without first trying to determine which ones are deficient and why they're deficient. And finally, treating for gut bacteria without first attempting to determine which dysbiotic bacteria are present. These are all examples that you're probably very familiar with, which no one really just treats for these things and doesn't try and know what's there in advance before treating. And the same holds true for diseases of the bowel. Another important point is that prior to beginning a gluten-free diet, and this is important for the physicians and for parents who are very new to this, baseline celiac antibodies must be obtained, and I can't overemphasize this enough. The only way to really know whether celiac disease is present, and it's very important for us to know that for a variety of reasons, is to get a baseline celiac titer, even if you're not heading towards an endoscopy, but to get those blood tests that we know that before a gluten-free diet, this was the status of the antibodies. What do we do? And I'm not going to get into this really today. It's a 4-pronged approach. For those children who have autistic enterocolitis, not the other things, but that one diagnostic entity, we do 4 things. We restrict their diet, and that may take the form of just taking out one food, a whole category of foods like gluten, most carbohydrates as an SCD, taking out everything, all proteins as in an elemental diet, or taking out everything totally, like giving TPN intravenously. Those are all examples of dietary restriction, and for different situations, one or the other is more or less appropriate. Anti-inflammatory medication, there are a whole host of medications that we would use in this condition, depending on, again, the location and the nature and the severity of where the disease is. The third approach we have to treat the bowel disease of autism is to alter their bowel flora, and that is done also by giving either antibiotics to alter the bacterial content, probiotics. Antifungals will do the same thing. It's an alteration of the bacteria content, of the flora content of the bowel, which we know is so beneficial in Crohn's disease and also is beneficial in autistic bowel disease as well. And digestive enzymes, which also has a hypothetical role in these children, which we're going to get into the theory perhaps later on in the question and answer period. I want to end with this, and this is very important, and it's crucial that all of you be aware of what's going on right now. On the right, you'll see the first page of a paper published in 1998 by Dr. Wakefield and others at the Royal Free Hospital in London. And it was a review of 12 children with ASD. It was a case report. They took 12 kids that they had seen in their GI clinic, and these ASD kids had regressive autism, and had ongoing either constipation or diarrhea, abdominal pain, or a mixture of those three. And they did baseline blood tests on them, found nothing wrong, did a diagnostic colonoscopy, and found pathology in 11 of the 12. Okay, the 12th one had lymphoid hyperplasia of the type that you've seen before. Most of those 12 patients responded favorably to sulfasalazine, and the paper in the last few sentences hypothesized a link with MMR, and a call was made for more research. A very benign publication. 12 patients. That caused the uproar that you're all familiar with over the ensuing 10 years. Well, this was the paper, and since then, a number of publications are published by the same group, and many of the same authors, that further characterize the nature of a disease, a much larger number of patients, and leaving the vaccination MMR issue aside. Just whether these 12 children had symptoms that warranted colonoscopy and biopsy, that question, did they warrant colonoscopy and biopsy, is the subject of an investigation now by the GMC, which is the equivalent, I guess, of the CDC here. It's a governmental medical authority, by the Public Health Department. And they've launched an inquiry with charges against 3 of the authors, Dr. Wakefield, Dr. Murch, and Dr. John Walker Smith. And the charges are specifically, and they center around the appropriateness of a colonoscopy and a biopsy in children who displayed all of the symptoms as the kids that you've seen in the hundreds and hundreds of kids that we've scoped in the ensuing number of years. So I'm asking you to please take a moment, write a letter to the GMC offering your support for these researchers and their work. And the key points to include in your letter: number 1, it's entirely appropriate for a physician to thoroughly research and investigate a child's clinical symptoms regardless of their developmental diagnosis. The label of autism should not get in the way of interpreting a symptom and thoroughly investigating it using all means at your disposal. Number 2, in your letter, mention that Autism Speaks has released a consensus statement on the GI disease in children with autism, noting the exact pathology that those 12 children had and subsequent hundreds of others have had since then, many of whom have been published as well. And again, you can download the statement from either Thorfel House's website or directly from Autism Speaks website that I had before. In your letter, encourage that open, unbiased research must be conducted and supported, and also be sure to include why it is that you're interested. Are you a parent? Are you a caretaker? Are you a therapist, etc.? You can send these letters to info@thorfelhouse.org, or mail it to Thorfel House, or fax it to Thorfel House. We will forward it to the appropriate recipients in the UK. And the second thing I'd like to ask you to do is to go online and sign the Nigel Thomas petition at the website that's listed over here. You will be asked for a donation. You don't have to give a donation. You can just close the browser and move on at that point. These 2 items are crucial. Thank you very much.
I want to thank Dr. Krigsman so much for taking his time this morning to share all this great information with us, and for helping my children too, of course. We're going to open up for some question and answer right now for Dr. Krigsman, if you want to stick around.
You want to go
Lisa?
first?
This young lady, yes.
Hey, first, I love you. You rock. You're the man.
I love you
You're
too,
amazing.
Lisa.
Now, the question is, all the viral panels we've done on Jeff have come back negative for any viruses, all the usual, herpes, blah, 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 EBV. And he's responding really well to Valtrex. And he has
Then
uveitis.
use it. Then use it.
Yeah, but what's the deal, dude? I mean, is it?
I don't know. I mean,
It's not supposed to work for measles, right?
It's not supposed to, but
Maybe it is?
You know, this may not be measles. You know, we
Okay.
don't know for sure. It hasn't been proven. It's lots of supporting data, lots of it. You know, has the absolute proof been produced yet? We're working on it.
Right.
And you know what? It might be one virus. It may be measles in one kid and herpes in another kid and something else in another kid.
Right.
You know, there was autism well before there was a measles vaccine.
Yeah.
So there's a lot more to the picture than we know.
Well, it's
so
just
that's why I always
anecdotally-
tell parents, I'm sorry, I always tell parents, if you find something that seems to work, stick with it.
I know.
And let us know what it is so we
But
can.
anecdotally, there are families, talk families who are your patients, that have no viral panels coming back, but are responding extremely well to Valtrex. And I just,
And they should use it.
and I want people to
and-
hear that too. Valtrex, woo!
Do you work for Valtrex? Okay, just. Yes.
Howdy, I'm Tammy Giles from the Seattle area. I have a bunch of parents that were asking me the same question that I have. I have a child who suffers severely from phenylsulfotransferase deficiency. That's a salicylate phenolic compound intolerance. Colizol will make him a gerbil in a cage. Yeah, same with sulfasalazine, any of them. Do you have any other recommendations?
Well, the first thing is to make sure you have the proper diagnosis. For those patients who've been shown that they need an anti-inflammatory for the bowel, there are a lot of other drugs that we use that are not salicylates. It's a whole slew of them. So by no means are you limited to just a salicylate. The salicylates are nice because they're the least toxic of the anti-inflammatories for the bowel, but there are many others.
Name them, please.
I'd rather avoid
just
naming the
suggest a
list
few.
of medications because they exist. They're there. We use them routinely in classic IBD, and they're the kind of things that you should be speaking with your gastroenterologist.
We don't have one in Seattle.
You need to consult with someone then. Keep
Sure.
looking, you'll find someone.
Thank you.
Yes.
Hi, I'm probably going to end up with the same answer, but my son has suffered severe gastric pain for years to the point where he will have.
I'm sorry, what was that? I didn't hear.
He has severe gastric pain, which they will even force him into seizures 3-4 times a day based on the pain. We've done the upper and lower endoscopy, colonoscopy, and found nothing. He did recently was diagnosed with a GTP cyclohydrolase deficiency, and they did find in an ultrasound, his GI, that he is having the small bile reflux back into the stomach. Unfortunately, tried Urso was the only suggestion he had, and it made my son vomit continuously.
What was that? I'm sorry, what?
He tried Urso.
Urso, yeah.
It made my son vomit continuously, and that was where we were left. Are there options? Are there drugs to help with
Right,
this?
so in your case, what I would suggest, this is an important point also, so you've been able to actually persuade a doctor to go as far as getting biopsies. That's wonderful.
He's
That's
trying,
a
yeah.
tribute. That's a tribute to your
I agree.
persistence and to their open-mindedness. It's really wonderful. If you've come to a point where there are no other options that are being pursued, then I'm happy to offer to have those biopsy slides sent to us.
Okay.
And we could look at those slides. And sometimes a pathologist that's not familiar in looking for the subtleties of the pathology that we see in these kids will overlook it and report the slide as being normal, when in fact it actually demonstrates the inflammation that we're looking for. And the reason that happens is because as a pathologist, pathologists do one of two things. When they look at a biopsy of any organ, they can say either no pathology noted or within normal limits, or no evidence of bowel disease present. In all those examples, if they phrase their report that way, what they're saying really is that what I'm looking at doesn't conform to a known disease that I am familiar with. So they're not telling you what they see, they're telling you what this is not. But that's not what I'm interested in. I'm interested in knowing, what do you see? Do you see even a mild influx of inflammatory cells? Do you see any evidence of cryptitis? And if you do see that, state so. That's what I'm looking for. So we may get a very different report from a pathologist who tells you what they see as opposed to one who tells you what this is not.
Well,
And
I
at
think
that point, we can move. We can take action.
Well, I know he became frightened when my son started to seize and indicated that these were just seizures because they did promote an abnormal EEG. Have you found other children who have such
Yes.
severe pain that they have flatline EEG?
Yeah, I don't know if it's the pain that causes it, but there's certainly reports in the literature of ulcerative colitis, for example, being associated with intractable seizures.
Okay.
And patients who've undergone a colectomy, removal of their colon for ulcerative colitis, and that being the cure for their seizures. So again, what happens in the gut affects the brain. It's complex. We don't understand, a whole lot of it. But there's no question that it is our firm belief, our meaning those of us at the Thoughtful House, that what happens in the bowel profoundly affects the brain. So even the seizures that they do have, it's so unusual to have, with the high frequency of seizures that these kids have, it's so unusual to find an abnormal EEG in any of them. It's rare. And I've seen so many hundreds of kids. So there's something different about the seizures in these kids. Outwardly, it's a seizure, but the EEG tracings of these kids, more often than not, is normal. Now, in your case, obviously, it was able
Right.
to induce something that's clearly a seizure, which is nice, because that way we can say we recognize what this is and we can treat it. But the possibility of there being an underlying bowel disease as a stimulus for the seizure activity is very strong.
Okay, thank you.
Yep. Yes, sir.
Hi, Dr. Krigsman. First of all, thank you for your work on this area.
You're very welcome.
And second, I have two questions. One, can you comment on ketotifen as anti-inflammatory drug for kids and side effects? And the other one is, how nasty is the Proteus mirabilis bacteria in the intestine?
What was I didn't catch the second question.
The bacteria, my daughter has, I think it's called Proteus mirabilis.
Right. The first question, as far as the anti-inflammatory effects of that drug, it doesn't have an established use in bowel inflammation. See, though there are anti-inflammatories galore, but the question is, what organs do they act on? So Motrin, which is a very effective anti-inflammatory for arthritis, for example, has no place in treating bowel inflammation because it doesn't affect the bowel for a variety of reasons. In fact, it can make it worse. So as far as I'm aware, ketotifen does not have an established therapeutic role in bowel inflammation. That's all I can say about it. Whether it helps some kids or not, that's a question of experience of different people that have tried using it. As far as Proteus being a pathogen in the bowel, again, there's not, there is some literature that suggests that might be the case. There's literature that does not suggest that's the case. So right now I have no firm opinion about Proteus per se. What I do believe is that, like in Crohn's disease, where we know a lot more about it, is that altering the bowel flora, irrespective of what organisms are there, just alteration of the flora seems to help so many of the kids as far as their bowel symptoms, whether it's because you're directing treatment to Proteus or Klebsiella or species of Clostridia, is far from clear. It's far from clear. So in practice, what I do is I'll give an antibiotic, like I would in Crohn's disease, and say, let me know what happens. And if something good happens, we stick with it. And if something bad happens, we change it. And that's the state of the science right now.
Okay. Thank you.
Yep.
Hi.
Yes. Hi.
I'm Jenny Kalis. I have a 5-year-old and a 7-year-old who drink Neocate. The 5-year-old drinks it for her sole source of nutrition. They drink like $1,400 a month worth of the stuff, and we're always battling with insurance. It's kind of crazy, but it's the only thing that keeps their symptoms at bay. And just to give you a little background information, we're on our 6th GI specialist. We haven't had a lot of luck getting to the root of...
What city do you live in?
We just moved from North Carolina to outside of Indianapolis to Fishers, Indiana, so we just started seeing Sue Maisel at St. Vincent's. But we'd been to, UNC and Duke and Cincinnati Children's. We've seen a lot of good GI specialists, and we've had a lot of trouble getting, any kind of a diagnosis for our kids. We're getting ready. We need to do a scope because my son's failing to thrive. He's growing as if he were 5 instead of 7. And we're having trouble finding a good source of anesthesia, I guess. You know, this study just came out in March about the volatile anesthetics like sevoflurane. It was out of the University of Pennsylvania, causing neurological regression. And so we're
I haven't heard that. This is recently?
Yeah, it was March of 2007, University of Pennsylvania researchers.
Okay.
They found that it increased the protein in mice, that the same one that is increased with Alzheimer's disease.
Okay,
And
so it wasn't on humans. It was just something on animals, and there was a hypothesis was raised. Okay.
But the researchers said, you know, if you think you have any genetic mutations for Alzheimer's, that they would strongly warn against this. And so we're having a really
Are
hard
they
time.
going to be investigated for scaring people against?
Well, yeah, I know.
We need to
I
find
know.
that out.
Well, looking back, though, the year that my son had 2 scopes and 1 surgery was the year that he got his autism diagnosis, so it makes us a little bit nervous. And so I was just wondering, is this what do you usually use this? I mean, our GI specialist wants to use it. She says it's easy. They're asleep very quickly. I mean, are these the type of, I know that you're not the anesthesiologist, but
Right.
it is a concern for parents like us who have done this over and over again, and we haven't gotten the
So your
answers.
question specifically is whether
Well, we just don't
whether
wanna-
we have experience with sevoflurane as being a problem?
Yeah, or do you use that, or what do you tend to use?
We use nitrous oxide.
Oh, you use nitrous oxide.
Unless parents really adamantly refuse it. Nitrous oxide, there's, you know, from where I stand clinically, I'm in the OR with these kids, and I've done close to 1,000 endoscopies now on these children. We just haven't had a bad. There are a couple of kids who do bad a day or two later, which will be the case with whatever you use, you know. But we don't seem to feel there's any untoward effects of nitrous oxide. But those parents who refuse to let us use it, we don't get in their way. We just use sevoflurane actually. So the other options that are available would be to put an IV in
And propofol.
give propofol. But if there's an egg allergy, then that nixes that. So
Is soy a problem with that one, do you know?
I don't think so.
Okay. And I just have another question. You said, my kids do have some eosinophils in their esophagus and in their colon, but we've been told in the past not enough to classify them as having EE. And you're finding that this is pretty classic in autism spectrum?
We see it very, very frequently. So I suspect that even though it's not EOE, it's not normal either. It's part of the problem, yeah.
Okay. And my kids are very sulfur intolerant. Are you using, is colazole, is that like a sulfur-free?
It doesn't contain sulfur. No.
It does not contain, and you're using it a lot? I was just
Yes.
curious. Okay. Well, I think that's it.
Okay.
Thank you very much.
All righty. Good luck. Thank you. Yes, sir.
Hello, I have a couple of web questions here.
Yep.
Question 1 was, in your opinion, generally, what is the cause of symptoms, viral or toxicity, and what do you lean towards if you have to choose?
Okay, I didn't catch the question.
Generally, what is the cause of symptoms, viral or toxicity, and what do you have to lean towards if you have to choose to treat one?
The cause of the symptoms in most of these kids is either inflammation or a dysmotility. Those are the two main reasons why these kids have symptoms, either of pain or diarrhea or constipation, is either inflammation, of which there are many types, and a problem with motility, and often those two coexist and go together. So, you know, I wouldn't classify it as viral or toxic. It's, you know, even if there was a virus there, what is the virus doing that's making you have the symptoms? That's the question. And the result and the answer, I think, is inflammation. It lies in understanding the pathways of inflammation, knowing which pathways are applicable to the majority of children with this condition, and then using medications that interfere with that inflammatory pathway.
Okay. And the second one was, has there been any work or studies of siblings?
Yes, we're very much interested in siblings. We're interested in siblings who are on the spectrum, who are not on the spectrum, who have bowel disease, who don't have bowel disease, who are immunized, who are not immunized, because we're going to learn a lot about the nature of familial tendencies and possible infectivity by looking at families. Yes?
Hi, I have a 9.5-year-old son who has been gluten-free for 5.5 years. We're going to scope him this summer. I was wondering, because our GI really wants to test for celiac because of my family history, how long and how much gluten should we give him? Because gluten-free diet was an enormous intervention for my son, and I'm terrified to give it back.
I'll tell you what we do. How old is your daughter?
My son is 9.5.
Okay. When was the last time he was inadvertently exposed to gluten?
5 years ago.
Really? Okay, so you're pretty sure
I'm a
that...
Nazi about it. I'm
okay,
really
you're a gluten Nazi. Okay, all right. You know, when I first began looking at these kids, I would insist, as we're taught to do, that to not start a gluten-free diet until you get your biopsy, which is what you've been told, and that's actually correct information. But when I told that to parents, I never saw them again. And I would lose a number of patients, and then they would lose a chance of being helped. So, so contrary to what probably is proper as far as diagnostically, I said, okay, well, let me just see what's there even on a gluten-free diet. And despite being gluten-free, we have this host of pathology that we're seeing. So, yes, it will be a more informative endoscopy if your son is on gluten. Okay, it is my personal opinion, though, based on no data other than experience, that if your gut feeling is that giving him gluten may slide you back 3 years, then don't do it.
Okay.
There's enough pathology in these kids that we can deal with, that we'll find with the gluten-free diet, that we can treat. So I wouldn't, on the contrary, one can make the argument, as I'm talking, I'm thinking that one can make the argument that in this, because we know so much about alternative bowel disease in this group of children, maybe it's better to not be on gluten, because if you're on gluten, that's going to cloud the picture. You're not going to get the full import of what we're finding on these biopsies if the picture is clouded by the inflammation that gluten causes. So, you know, one could make that argument, actually. I'm going to give that some thought out. Thank you for making me realize that.
Okay, and then the second question I had briefly was my son had a blood test positive for H. pylori, and then the doctor saw it and he said, you know what, we want to avoid him bleeding out if there's ulcerations. He put him on Prilosec. We did a stool test. The stool test came back negative, but the Prilosec made an enormous difference to my son's for the reflux. Is the Prilosec going to change the pathology of his esophagus?
Yes, it will. Oops. The Prilosec blocks acid production. Okay. So, you know, whatever pathology you're going to see in the esophagus that's a result of acid will be improved by Prilosec. In our experience, these children have an underlying esophageal disease, stomach disease. It's exacerbated by the presence of acid, so that you get this, again, this mixed picture when you get a biopsy. But, you know, there's no, if you saw a definite improvement on Prilosec or Prevacid, yet there are still symptoms that persist that still justify an endoscopy, leave him on the Prilosec, because that, again, that way you might be better able to discern the underlying autistic-related bowel pathology. So, you know, you can argue both ways, and either way, on or off Prilosec, it'll be a very informative biopsy.
It will. Thank you.
Yep. Yes.
Hi. We brought our son to you when he was 4 years old, and he did much better when he was started on Prevacid and sulfasalazine.
How many years ago is that?
He'll be 7 in August, and it just made a world of difference for him. But when he turned 6, he started having new symptoms again, stomach pain, you know, just some more symptoms, and we went locally. I talked to you on the phone, actually.
Right.
We ended up going locally, and they did find more true food allergies, IgE, true food allergies.
On blood tests?
Mm-hmm.
Okay.
Yeah, on blood tests, and they found the eosinophilic esophagitis. They called it eosinophilic esophagitis, but they said it was very few.
Oh, so he was rescoped?
Yes.
Okay.
Only the upper scope.
Okay.
And they did a round of Flovent, and all the symptoms went away.
Right.
He'll kind of pace and growl, make noises, and those symptoms totally went away. But they came back, you know. So just empirically, they did another round of Flovent. I don't remember how long after the first round. Symptoms totally went away.
Right.
They're back again.
Right.
So she wants to do another upper scope. Do you think the Flovent truly just relieved the eosinophilic esophagitis and that's why the symptoms went away? Or do you think just the steroid potentially helped something else going on that's not?
Well, in the case of Flovent, the steroids is a question. They're acting topically on the
Right.
lining of the esophagus, and that's why the symptoms get better. And the hope is that when you come off the Flovent, the symptoms stay gone, and that's usually what happens. But clearly, there's something that's triggering this eosinophilic response. So the diagnosis is EOE, perhaps, but the question is what's triggering that to happen, and what could you do more to help that? So at this point, it's your daughter, right? Your daughter? Son. He's being treated for EOE, but my question is still, what's making that happen, and is there more that can be done? And perhaps the answer is yes.
Maybe another trip to you?
Well, a phone call for starters. Yeah,
okay.
We'll see where it goes from there. Yeah.
Okay, thank you.
Very interesting story. Send me the path reports, both the endoscopy and the path reports. I'm very interested in seeing that. And do a blood test also for IgEs to foods as well. Send all those. That very, very interesting story. Okay, thank you.
Hello.
Yes.
I have an 8-year-old son who, when he was the age of 4, he was diagnosed with moderate autism. But now I think with the diet, it's gotten to mild autism. And I also have a 3-year-old daughter who has the distended belly, kind of skinny arms. But she has developed speech, and she is social, but she just has more of like an apraxia. But what I notice when I give them probiotics, they're more verbal, more social, more eye contact, and I notice it within like a couple of days. They also do have, when I give them the probiotic, diarrhea, but then that eventually goes away. What I was wondering is, I haven't done the battery of tests yet on them to find out what's going on in their GIs. Should I stop giving the probiotic until I have the test done and then give the probiotic afterwards to see if it's having some kind of an effect? Or
Well, if you're seeing improvement, clinical improvement in their GI symptoms, then that's the answer. That's a poor man's test.
It's a poor man's test.
That's a poor man's test.
Okay.
If what you're doing seems to be helping, you don't need necessarily a
But
test.
with my daughter, though, the belly will come back after, like a month of not having it.
So keep her on it.
So just keep them on. Okay, I just wanted
I mean, that's,
you said not to
now the
change.
question is now, what's interesting, when I hear this story, what I'm interested in is when you find that you have a child with developmental disorders, whether it's apraxia or ASD or whatever you want to call it, whatever intensity is present, who has a distended belly that seems to get better with probiotics, that suggests that something that we discussed is going on. And is there more that we could do that would be more effectively treat the disease? The answer may be yes or no. It might be that, if she were to have someone look at her gut, you'd find nothing at all and stick with probiotics. But the answer might be yes. And then the question, of course, the real $1,000,000 question with all of this is, if you treat the gut, can you help the brain?
Right.
And so that question always looms. And we don't know what the answer to that question is. We really don't. But that question is always looming. Is there more that we can do for the bowel that will give me a better outcome with their spectrum-related disease? So that's always kind of, it's always looming. So it's something to consider.
And the doctor that we're seeing is, we're going to be seeing is Dr. Cindy Schneider in Phoenix. And I don't know if you've heard of her.
Sure. Cindy, yep.
Good to see.
Yep.
Okay.
Absolutely. Yes.
Hi, doctor.
Hi.
I also brought my son to see you a couple years ago. We had all the scopes done. We did not do the pill cam. Our son wasn't doing very well on any of the drugs. You probably don't remember, or maybe you do, but we got all the way to 6 MP, and he ended up getting 5th disease. We had to take him off, and we actually got scared away. So yesterday I mentioned something to Dr. Wakefield, and he said that we should probably do the pill cam. And then he mentioned Enterocort? Is that the, he said it's a
There are
non-invasive.
all kinds, yeah, there are all kinds of medications, there are lots of options, lots and lots of options.
Do you use Enterocort frequently?
If he
or-
swallows pills, we could use
He
Enterocort.
does not swallow pills.
We won't be able to use it. But there are other options. There's always, there's
Like
not just
we-
one or two options. There's
You had
lots of-
mentioned we could do methotrexate at the time that we went off the 6-MP, and we just,
Right.
we were kind of at our wits' end, so we...
How many years ago was this?
Might have been last year. It was last year that we stopped, last May, when he got the 5th disease. So it's been about a year.
So we'll see. I mean, some kids are tough. Some kids
Yeah.
are just tough to treat. When he got 5th disease, things got worse. His GI issues got much worse.
I think they did, yeah.
Because typically when kids with bowel disease and autism get a virus,
Oh, they did, right, because he was potty trained, as you had, that was, the big guarantee. We did get him potty trained. He was having the really beautiful stool, if I could say that. And I'm
I'm
sure
very
you
proud
all
of
know
that.
what I'm
Please
talking
say it
about.
louder.
And then he started with the diarrhea again, and he hasn't had solid poop since, so.
something happened, okay? Something happened to him, and that's the question is what? So sometimes it takes more investigation.
Okay, and the second...
I always tell patients, if you stick with me, I'll stick with you. So, if there are...
Well, we still love you. We just
Well, that's
got
okay.
very scared.
Sometimes some kids have a rockier course. There's one woman sitting in this room right now she knows who she is, who's had an incredibly difficult course every step of the way, and just keeps. I mean, she inspires me. She keeps trying different things, and to find the thing that works. Sometimes and very often, more often than not, it's not a rocky course. We find the right 1 or 2 or 3 things with dietary interventions included that helps the majority of kids. Some kids need some more diligent work, and maybe yours is one of them.
Yeah. My other question is, when we put him on the 6-MP, he got 5th disease. And interestingly enough, my daughter was just exposed to chicken pox. She was vaccinated but didn't have all the titers, and so she has a very mild course right now. We found out the day we got here on Thursday. My son is exposed, and instead of getting chicken pox, he has 5th disease. What's your take on that? Any?
I don't know.
Is there any kind
As far
of
as I know,
relationship?
there are 2 different families of viruses, I'm pretty sure. I mean, chickenpox is a herpes virus,
Yeah.
and 5th disease is parvovirus, which I don't think is a herpes virus. So, but even if it is, they're 2 different viruses. So, a 5th disease, by the way, is unless blood was drawn to document the titers, it's more of a clinical diagnosis. So you see, a characteristic rash, and we call it 5th disease, and there's no recommendation to do blood tests on it. My point in saying this, though, is that what you say is 5th disease may or may not be parvovirus B19. It might be some other virus that just looks like a similar rash to 5th disease. So, but it's an interesting story.
Okay. Thank you.
Okay. Yes, ma'am.
First off, I'd like to say thank you so much for spending so much time with us.
You're very
It's
welcome.
fabulous to be able to ask some questions. I have a question about, my son has very distinctive issues with gluten. When he's on gluten, he vomits, he cannot concentrate on anything. I have him off of gluten. I've had him off of gluten for 3 years now. He's 4.5. So we were not able to get a biopsy. Went to a gastroenterologist, I'm from Chicago, who specializes in celiac disease. And he said, let's do the genetic testing, which is a blood test for it. He came back without the gene.
Right.
He said, therefore, put him back on gluten. He did an IgG panel, he did an IgE panel to find out what kind of sensitivities he may have, came back insignificant for everything, and sent me home. I put him on half a piece of bread, and he vomited for 4 days. So obviously I took him off of it because that's working for me. So what I ended up doing was going and looking into allergies on a histamine level.
So he did not have a biopsy while he was on gluten?
Did not have a biopsy,
Right.
but the doctor told me since he
didn't
doesn't have the gene,
Right. And he didn't have any other blood
and he doesn't
markers
have an
for celiac
allergy
disease also,
to
right?
it, supposedly, yeah, that pretty much you're nuts, go home, and, so I'm kind of like not sure what to do if this is, not that I have no intention of taking him off of gluten. But it's not logical to me. I'm not understanding why. I mean, and I've been to several doctors, not just GIs, but that say, I don't see, we can't find anything wrong with him, so therefore, what you're doing probably isn't really working anyways.
This is, and this kind of question is, I alluded to it before, and it's bothered me from a psychological approach. What is it that we're seeing in these kids that baffles excellent physicians?
Right, and
excellent.
these are
This
fabulous
is the big city.
physicians.
You have world-renowned gastroenterologists here that know a lot more than I do about so many diseases. So what is it about what you're going through and other parents that baffles them? So this goes back to, to the issue with the pathologists, is that when you see something new, are you going to look at it and say, hey, this is not what I recognize that I know. Maybe it's something new. I'll look into it. I'll investigate it. Is that as a human being, never mind the physician, is that how you approach life? Or do you approach it as saying, well, I'm going to make what I see fit and conform to things that I know and treat it that way? Right. And it's human nature. We do it, in all areas of our life. But you're bumping up against it with science and medicine. And that's it. So what you are seeing, to answer your question directly, is that this is a non-celiac, non-IgG, non-IgE sensitivity to gluten. And that is not a novel concept. You go to any allergist, right, and allergists will tell you that there are kids who get hives from eating foods, but their IgE is negative, and their IgGs are negative. So they tell you, don't eat that food. Right. That's what they say, because that's all we know about it. And that, I think, is what you're experiencing. So this is a non-celiac disease, non-IgG, non-IgE sensitivity to gluten.
So the genetic test is accurate, even if you're not on gluten. It's a genetic test, right?
Right,
it's
exactly.
Either you have the gene or you don't.
Well, that gene test. It will diagnose about 90% of celiac patients. In other words, take a celiac patient with bona fide celiac disease, 9 out of 10 of them will have this genetic deficiency. Others will have other mutations of that gene. So we don't test for every permutation of the gene. It's too expensive to do that. So it is possible. And same thing with cystic fibrosis. You have a patient with CF. There's one gene responsible for almost all CF patients, but there are other gene mutations that are responsible for the rest. But it may be that we tested for every celiac gene, and they'll all be negative. And that's probably what would happen. And I wouldn't recommend pursuing that, because they're going to stick you with the bill at some point.
Right. Not only that, but he's not going off gluten anyway.
Right. And yeah. Right. So that's what you do. So the gluten-free, and this underscores the importance of listening to what parents say, because that observation of gluten making a difference was not an observation made by physicians. It was parents who kept saying the same thing.
But it's so black and white too. I mean, vomit, no vomit. I mean, it's not like there's even like you can kind of construe something.
It makes you nuts, because why can't you listen to me when I tell you that? And it's very frustrating. So
thank you very much.
Yeah. Yes.
Dr. Krigsman. I'm in a kind of a unique, well, it might not be so unique, but I have a little 4-year-old who has none of the behaviors that you talked about consistently. This little guy just has what I would call inflammation, which I know is inflammation because when we did hyperbaric, his bowels got a lot better. And he also has the poop. That was his poop, what I saw. But I'm in a situation where legally I can't do a scope. So is there anything that you would recommend, to help me until I possibly can scope? I have an ex-husband who's not on the same page as me.
Exes usually aren't. That's a question that we'll speak about probably. Okay. You can call me. We'll discuss what the options are, because I'd have to know more about the legal situation, obviously, before making a recommendation.
Well, I can tell you he's a physician, and he has medical decision-making with me,
Right.
but
Well,
doesn't
we're
live in the same
and
state.
we're certainly, we meaning us at the Duodenal House, is certainly available for, phone consultations with anyone at any point about any topic. And you can call Wendy at the Duodenal House, and she'll be happy. Wendy's right here in the front row.
Okay.
Give her a call and see if she can coordinate some sort of a conference call, whatever it is that would be of help. We're available for that.
Okay, thank you.
I've got two quick questions. Can you just do the pill cam to cover the entire GI?
Oh, I was waiting for that question.
Is that just because my son will swallow pills as long as it's not
Right.
gonna
The
choke
pill
him?
cam is a revolutionary technology. It was designed to image the small bowel. So it doesn't image the colon. It doesn't image the esophagus or stomach very well, for that matter also, but it's great for the small bowel. Stomach also is pretty good, but not anywhere as good as an endoscope. The limitation of the pill cam is you can't get a tissue biopsy. And although the findings that I've showed you today were all endoscopic and visual with the eye, there are many times where visually it's normal. It's only on biopsy under the microscope, and I showed a few of those slides, that you see the pathology. So, the question is, and we've gone back and forth at the Duodenal House about this, for those kids who can swallow the capsule and don't need to have an invasive endoscopy, and they have the right story and the right symptoms, and you do a pill cam, would that be enough? And my gut feeling is no. And I say that because it's still so important for us to get the tissue, to get a biopsy. Yes, if you got back a pill cam study with clear evidence of Aphthous ulcerations and bleeding, and then that's pretty good. And in that situation, would you be willing to treat without a tissue diagnosis? That's a question that we can go back and forth with. But for the most part, we'll find Aphthous ulcerations in the small bowel, but we would like to have something that we can microscopically make a diagnosis.
You wouldn't necessarily do the pill cam first to be certain and then go back in. You'd like to be...
On the contrary, I would do, I've always thought of it the reverse. The parents always ask it this way, and I always think
less
of it,
invasive is the reason
I always
why.
think of it differently because it's less invasive, but what I would say is that I would do the tissue obtaining diagnostic procedure, and if that gives the answer, we don't need a pill cam.
Right.
And in fact, I discourage pill cams. A lot of parents come in, they want it, they think it's really either they think it's crucial, or they think it's just cool to have, or whatever. And
I'd say just less invasive.
yeah, and I
thing.
discourage
Poking
it
and prodding,
because we 9 times out of 10 we get our answer doing conventional endoscopy and a biopsy. And the other thing is that we don't have. Okay, we haven't got the precise data yet, scientific data, that correlates the pill cam finding with the histopathology on the biopsies. The real way that you know that what I showed you is true is that you have the same patient and you get concurrent biopsies and pill cam studies and show that there's a correlation with them. And although we've seen that, that's been our experience, we haven't sat down and put the numbers into the spreadsheet. Until that's done, it's hard to recommend that being a diagnostic study, because at this point it's not.
Okay. I've got one more quick question. We have a lot of blood work from other physicians. Is there something, I know that Dr. Mumford mentioned that neutrophils were a sign of gut inflammation.
We're a sign of what?
Neutrophils.
We're a sign of?
Were, if they were elevated, that it could be a sign of gut inflammation.
Right.
Are there other tests that I may possess that would lead me to believe it's a good idea to really pursue investigating the GI?
The reason to pursue a GI investigation is not from a blood test, it's the symptoms. What we've learned in our experience that the symptoms drive the workup.
Right. Well, my son certainly had a lot of them.
Yeah, most of the time is the blood test are normal.
Okay.
The blood tests that look for conventional IBD are normal, yet the symptoms are real and they're intense.
Yep.
So it drives the workup as the symptoms, not the blood tests.
All of our mothers' observations, and fathers, too. Thank you.
Hi.
Hello.
Our son had a Meckel's diverticulum, and I was wondering if you've seen that with any of your other
No,
ASD kids.
I have not seen it in any of my patients, but I'm sure that, just statistically, it's got to be there. How is that diagnosed?
One day out of the blue, he just all of a sudden had a bloody stool with the dark, old blood. And so we went in, and he ended up having it surgically removed. At the time that they scoped him, there was too much blood to see if there was anything else going on. We got a good upper look, but we didn't get a very good lower look.
And what they find?
So they said they didn't see anything else because they couldn't really see, because at that time there was still a lot of blood in there. But they said it could be completely unrelated to anything else that he's going through.
Meckel's is just an anatomic, curiosity.
So it was just by chance that he happened to have that along with
as far as I would know,
anything else? Okay, well, thanks.
Okay.
Let's give Dr. Krigsman another round. And I just want to hug all you ladies up here crying, because that was me last year on the front row crying, and I'm still crying but they're getting better this year, and there is hope. They will get better.